morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to another episode of ACNS webinars. The speaker for the first session of today is our honored guest from Israel, Professor Ido Paldor. Professor Paldor is the Vice Chairman of Department of Neurosurgery and attending neurosurgeon for the brain tumor and radiosurgery, as well as the Director of Training and Teaching at the Rambam Healthcare Campus, Haifa, Israel. He is also the Vice President of the Asian and Australasian Society of Neurological Surgeons. He is an invited faculty to several workshops and conferences worldwide. We are extremely honored to have him today at our webinars, and today we'll be talking about developing training models for residents in neurosurgery. The speaker for the second session is our honored guest from China, Professor Su Gao. He is a consultant neurosurgeon at the Department of Neurosurgery, General Hospital of Northern Theatre Command, China. His clinical interests are focused upon endovascular neurosurgery, and we are extremely honored to have him today at our webinars, and he'll be talking about endovascular management of carotid cavernous fistulas. The chair for the first session of today's webinar is our honored guest from India, Professor Nupur Pruthi. Professor Nupur is a professor and unit chief at the National Institute of Mental Health and Neurosciences, Bangalore, India. He is in charge of the animal lab at the NIMHANS, and he has developed several training models for training of young neurosurgeons. He has organized several workshops in vascular anastomosis, and he is also an invited faculty to several conferences around the world. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from India, Professor Girish Rajpal. Professor Rajpal is the Associate Director of Neurointervention at the Max Hospital, Delhi. His clinical interests are focused upon neurointervention and is a full member of the European Society of Neuroradiology. He is an invited faculty to several workshops and conferences organized worldwide. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. Dr. Liubun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Nupur Pruthi.
Thank you so much, Raja and Professor Koto, for this kind invitation. And this is a topic which is very close to me. And I think education is the best gift we can give to our future generation. The topic of today, developing surgical models for resident training in neurosurgery by Professor Paldor, I'm looking forward to it with keen intent. It is a very pertinent topic and the need of the hour. Lab training is extremely important. I did my fellowship with Professor Ugur Ture and Professor Yasargal in Istanbul, and both are of the firm belief that every neurosurgeon has to spend at least 6 months in the lab, if not more. In my opinion, experimental models for training are of 3 types. The first models, they teach us anatomy and improve in our anatomical understanding of the brain and other spine. The second type of anatomical models improve our hand skills, the dissection skills, the suturing skills. They're very, very important, and both these things are very important for the surgeon. And the third type of models focus on how to improve our clinical examination skills. I think these are the 3 models, in my humble opinion. With these words, I request our invited speaker, Dr. Paldor, to start his talk, and I'm looking forward to it.
So first, I'd like to thank the organizing committee for inviting me to talk. And I'd like to talk today about creating surgical models during neurosurgery training. And I'll elaborate what I mean in a few minutes. I'll just note from the start that I've been director of training and teaching. It's one of my passions, and I've been director of training actually anywhere I worked. And I'm very keen on finding models and training residents and young neurosurgeons. So I'll talk a bit about that today. I have no conflicts of interest, or as my and the main problem I think is that like Max Planck said that science progresses funeral by funeral, and this is especially true for neurosurgery or for any surgical training, where many patients, when I say many, I mean all patients, are pretty reluctant to have an untrained resident operate on them. But when you think about it, between the day you were an intern and the day you retire, there will be one day or one time or one moment when you actually do this procedure alone for the first time. But none of us would want our loved one operated by someone who's never done this procedure before, but someone will meet the person who's doing it for the first time. I think there's a real need for surgical training models. And I will point out that Professor Puthi, who's the chair now, has a world-renowned animal lab. But as he will certainly tell you, animal models are wonderful, and we've all practiced with them, and everyone should practice with them. But those are expensive. I think one of the models my residents liked the most was with a pig model, but then it was quite costly, so we couldn't use it more. So no one actually wants to pay for the training models, and I don't think in any center in the world or any country in the world is there a good answer to the question, where will the funding come from? So I'm trying to describe today a cheaper way to develop models. So the subtext maybe of this talk, and even more so, more relevant to low and middle income countries, is a cheap model for resident training. So how do I go? This is my model about how I find models. So first, I want to be inquisitive both in operating theater and in life. And after every failure, it's anyone's intuition to say, well, we did everything right. Everything was good, but it was just a mishap. But I think if you're inquisitive about what went wrong, and even more so, you want to ask yourself, what is the need for the resident, or if you are the resident, what is the need for me to improve? What precise part of the procedure did I misperform? What can be done? And then, if you can, try to find, and I'll give a few examples in a few minutes, what process in your life resembles this exact surgical ability. Then you define the need. And what I mean by define the need is, I want you want to be specific. You don't want to say just suturing, or give the residents a few, or the trainees a few sutures and a needle holder, and have them suture something. Not even let's give them chicken wings and sutures and have them suture, because that's not good enough. You want to be specific in what the need you want to achieve is. As an example, not only do you want them to suture, but you want them to create watertight sealing. Or alternatively, for the same procedure, it's still suturing, you want to create tensile strength compared to, so be specific in what exactly the need or the goal you want to achieve is. Then the third step is to define the model, and preferably it should be a measurable model. So the demands I usually hold for the model I want to have is it must require the skills that you just defined in the previous step. There must be success and failure. Again, if you take a bunch of sutures and give a chicken wing and have them suture, what did they do well? Did they do poorly? When did a 6-year or 5th-year resident, an advanced resident, do this better than a first-year resident, etc. So you need to define what is success and what is failure, and preferably not only do you have a good yes or no phenomenon, meaning it's good or it's bad, meaning success or failure. Preferably, and I'll give again a few examples, you can measure success or failure in something measurable. And again, I'll move in a minute to examples. And the last part, and I stress this, although I won't talk much about it, but I do stress its importance, is have it ready wherever you're going to set this model up. Have it ready. You don't want to start running have everything set up and then say, oh wait, but I forgot that I need pickups, or I need scissors, or I need to dissect with a dissector, or etc. And the last point, which I've already alluded to a few minutes ago, it cannot be expensive. If your model requires 10,000 euro every time you want to employ it, it will often not work. Okay, so just to summarize the process: identify the problem, define the exact needs, what you want the residents to do, and build your own model with measures of success and failure. So here, let me give you my first example. This is a patient operated not too long ago with simple convexity meningioma, almost parasagittal, but not. And then the postoperative CT, which you see on the right, showed reasonable, no mass effect, but you can argue with the fact that there is arachnoid bleeding there, subarachnoid, sorry, bleed there. And what I explained to myself is that no, nothing happened. This is a classic example of what I said earlier, where nothing happened. The patient was fine. There was no neurological deficit. We followed up with another CT, which was okay, and everything went well. There was no problem. So this is a classic example of saying, okay, well, no, there's nothing to fix because the patient did well. No, but here there was a problem. The poor dissection led to violation of the arachnoid plane, and this in turn led to subarachnoid hemorrhage. This is not a normal outcome, and you want to avoid this. So then what we did was we want to train the trainee for dissecting gently. And then I thought to myself a few days later, if only there were a naturally occurring delicate membrane that is available for dissection. And then we thought, honestly, this was a few years ago. You see, we already published it in 2020, but for the story it was, but then we actually thought about it. And then what we did is we would put, you can see in the middle picture here, on the left side, you can see one of my residents operating under the surgical operating, so to speak, under the surgical microscope. And the goal is pretty simple. What you do is you tell them you want them to take a section of the orange, take it out, and you will be measured by the quantity of juice that you spill during the dissection. Meaning, ideally, what you want them to do is to dissect gently, take reasonable time, and dissect away one segment of the orange without violating the, so to speak, arachnoid plane, or the I don't know how to call it, the membrane of the orange. And this was reproducible in a way that I can tell you, those of you who are curious can read the article from World Neurosurgery, where it was different between residents of different experience, and you could actually see improvement along after a few tries and so on. So it was a successful model. Okay. Here's a problem another example of a problem. Well, the problem of CSF leak, which is normal. And again, once again, no problem. There was no issue. The patient, this patient did have an actual external CSF leak, but we wanted to train our residents with watertight suture. So what we thought about was here's a different model, where what we did is we took a bag of saline, which you can see here on the left, and on all the bags, we drew this inverted T. You can see that the T is inverted, meaning that the horizontal line is at the bottom, right? And then when the resident is ready to start, they have a lot of sutures and suture holders and staplers and whatever suturing, thicker, thinner, whatever they want in order to suture. And then when the resident is ready, what you do is you cut the line from top to bottom, the other line, you see, not the horizontal one, and you just cut it, where, of course, if you lift it up, the fluid would spill. And then I give them as many sutures as they want, whatever they want. They need to suture this horizontal line. Again, we haven't touched the horizontal line, just the vertical line. And they need to resuture the vertical line until they're done. When they say, okay, I'm done, I think it's already watertight or close to watertight. And then what you do, which you can see on the right side, is you hang up this bottle, this bag of saline, and your measure of success is you measure from the second you hung it up, you measure how long it will take for the fluid to get to the horizontal line, meaning how, because you can never actually suture it watertight in the terms that it will not spill at all, but the better you suture, the longer it would take the fluid to go down to the horizontal line. Again, a model which hopefully requires what they needed and what the skill that I wanted them to train with, and it's measurable in this case in time, whether they succeeded or not, and what was success or failure. Here's the third example. This actually, I have to admit, the reason I didn't publish this was because I actually saw it in a course that I took back when I was a resident 520 years ago. I saw this practice and I just copied it. And the challenge, which we all know in practice for any craniotomy, for beginning any craniotomy or just for a burr hole, you need to drill through bone towards a delicate membrane, which is the dura, and you must not violate the membrane. And then what you want, of course, is a model that has a hard drillable shell, but has a delicate membrane underneath. And what you do with the model is you just here's again on the left, you can see a resident of mine drilling down the egg. In this case, it's a soft egg. We'll get to a hard-boiled egg in a few minutes. But here they will drill down the soft egg. And the goal is, first of all, not to spill the content, the fluid content of the egg, and to not violate the membrane underneath, which those of you who noticed there is actually a drill. I will not go into, in a sec. I will not go into there was a scoring system for this. Each resident at the end of their practice, just as you can see on the left, they wrote their name here, right? They wrote their initials on each of the eggs, and then I graded it, but I won't go into it because it's a difficult grading system. But there is a grading system, again, defining and measuring success or failure. So that's an example of a model for drilling. And the fourth and last model, which I will show you, is the CUSA. We all use the cavitronic ultrasonographic aspirator, and usually, it's better if you can tailor the settings and the use of CUSA to the consistency of the tumor and the need to select it from surrounding tissues. We all know that you can modify and work better with CUSA or work worse with CUSA by both the practice of working with it and defining the settings, again, the amplitude of the or the irrigation and or the tissue select, etc. I won't go into all the CUSA settings, but I hope you know what I mean. So then in this case, I wanted a model that has different consistencies within, and both can be removed with CUSA, again, mimicking the brain, which if you wanted to, you could try and remove with CUSA, and of course the tumor, which you could try and remove. So we took the hard-boiled egg, which you can see here on the right, and we built the model. Where what we did there was what we did is we measured a 1 centimeter. You can see in the left panel D, segment D, we measured consistently a 1 centimeter circle on the hard-boiled egg, and then we gave the resident the CUSA and the hard-boiled eggs. Now, it required them to do a few things. One was to drill through the shell of the egg, which you can do, but of course you need higher or more amplitude, higher amplitude settings to drill through the shell. And then what my assessment, or what I defined that they need to do is that they need to, once they've gotten through the shell, they need to remove as much yellow as they can from the egg with minimum violation of the white part of the egg. And what you can see in the right side of the panel is the results. At the end of the training, what we do is we take the egg, we cut it in half, as you can see in panel E, and then we look at how much of the yellow part was resected. Again, you can see an example of an advanced, I think this was a 6th-year resident on panel A, where they were successful in removing almost all of the yellow with minimum injury to the white part. And whereas what you can see in panel B on the right is an example of a 1st-year, or maybe it was even an intern trainee, in which both the approach was not very successful, which you can see with the cone heading in, and not all the yellow was removed due to this result. And you can assess all of these elements. Again, those of you who want the details, welcome to read about it in the article. So, we ran through this quickly. So in summary, what you want to do is you want to define the need, what exactly you want the residents to learn. You want to be creative with the model. I will tell you, I'll leave you with this notion. You are surrounded with models that mimic neurosurgery applications and neurosurgery abilities. And as long as you will be creative with the model, you will be able to model at least one part of the surgical abilities you want them to have. But it's extremely important to have measures and definitions of success versus failure. I put my emails down here in case anyone wants to ask or further more than now on the YouTube channel or whatever. And I thank you for your attention. And if there are any questions, I'm happy to answer them.
Thank you, Dr. Paldo. That was a really nice and very informative slides. And I think this should have been a must for every resident to watch. I think the purpose of education is not to just impart some lessons for them to just learn or to just give them some instructions. They should be thinking. We need to make our residents think. I think that was the first point which Professor Aldo told you, that you first need to understand the problem. That will only come when you go inside yourself. You need to have insight. You realize the problem. That was the first point which Professor Aldo made. And when you realize the problem, the things will follow. My first question to Professor Aldo is, you told us so many models, interesting models, but you need to fix those models, So we need to fix those models in a place so that they don't move. So I just wanted to know, how do you achieve that? It's very important so that they don't move.
So some of them, I actually like it to move. For instance, with for instance, when you're suturing, often the skin will be mobile and you want it to be able to move a bit. Whereas drilling is usually done, or often done, in a fixed setting. Yes. And what we do is we usually put it in a cup. A cup is useful for a few reasons. A plastic cup, you can use it for a few reasons. First, you can easily fix it. You just put either an egg or an orange or a coconut if you want, whatever. You can fix it in so that it doesn't move. The second advantage of a cup, which I kind of talked about with the orange model, is that it collects fluid, and therefore you can end the drill, remove the orange or strawberry or whatever you wanted, and then you can see you can measure how much fluid was in there. And the third, which is a model I'm actually thinking about now, is that in a way, a cup may mimic dissection along, let's say, the sphenoid ridge or the pyramid, where if you to just suture, I'll give you an example. To suture just a plastic bag is easy. You don't need a neurosurgery trainee to do it. But sometimes you will need to suture or manipulate in a depth inside the Sylvian fissure. So the third use of a cup, which I'm trying to work on now, is to have them do it either drilling or working with kusa or suturing inside the cup, meaning the cup is fixed and you need to do it in the end of it. So a cup in my hands is very useful for many reasons.
So my second question is, Professor, now we have residents at different levels of training. We have first years, second years. The course here in India is 6 years. I'm not sure what is the duration of, I think 6 years.
Same. Yeah, same here. Yeah.
So what do you give them different tasks to finish in first year, and then you change the task in second year? Do you have a proper program for the residents for the lab?
Yes. So I will do scheduled days. I will make kind of like a grades or something for each resident, and then the next time some of the models will repeat. I will admit that some of the models are just unsuccessful. You take them in either the feedback you get or the differentiation. You'll have a 6-year resident who got a very low score consistently, and so some of the models, it's a bit of a trial and error. But I will have, at least for the models that will persist for future days, I will have kind of like a report card, so to speak, and I want to see that they improve, and I will allow them to cheat, so to speak, meaning if one of them wanted to, and I've had this, one of them said, I was on call, there wasn't much to do, so I went down to theater, I took a hard-boiled egg, can you remind me what exactly how you do it? And I said, sure, you do this and that, and so on, and they will work on it. They don't need me to have a hard-boiled egg. I mean, they have the technology to boil an egg themselves. And then they'll just do it themselves. And if they cheat, so to speak, and get a better grade, that's good. That's good for me. They practice the surgical needs, so I'm happy.
So one is success and failure is you have given very fixed criteria that is very important. Absolutely agree with you. But what about the time? How much time do they spend? Do you want a cut on that? I mean, how much time a first year should spend, second year should spend in the lab?
So I have to admit that time is both a dependent and an independent variable, meaning I will say you have, for example, in some of the models, I will say you have 10 minutes to do it, whatever you succeed, because if it took you 3 hours to remove the yellow part of the egg with the kusa and you succeeded, that's impractical to do it if it takes me 5 minutes or 10 minutes. So there is a time constraint in that aspect. And I will also note the time it took, meaning because I have when they practice with a surgical microscope, I say, I'll help you to set it up when you cheat, or so to speak. But my only demand is record it and I will see the video. And so I have measurement of time, how long it took them to resect the yellow part. And then I'll note that. And I also want to see improvement in that.
So recording is very, very good point, and very, very, I think it's very important when our training our residents, and it's good for them. It's just not trying to impress your professor. No, that's not the idea. Please don't get that idea. You need to focus on your improvement. That is very important. Raja, do we have questions from the chat?
Yes, I think Ben has raised his hand. Ben has joined us from Hong Kong. He's a young neurosurgeon. Yes, Ben?
Ben, please go ahead.
Yes, hello, Professor, and thank you for your very interesting lectures. So as I mentioned by Chairman, so we have trainee from different levels. So my concern is how would you advise trainee who want to do a vascular or bypass? So what are the steps of the in-house training you would advise for them to gradually acquire the skills for those vascular bypass or aneurysm surgery? So what's your opinion?
So I generally think that vascular is the most challenging part to train anyone with, actually, because the main issue, in general, I'm a brain tumor guy, but I think I'm sure my vascular colleagues will agree that one of the biggest challenges there is the fact that there's blood flowing through the apparatus that they're operating on. There's an artery or a vein or both with blood flowing, or an aneurysm with blood flowing through it. And I can't say that I've been very successful with modeling other than with animals. Meaning, I will admit that I was for almost a year and a half, I was a rat surgeon back when I was in Hopkins. And I think the lab almost went bankrupt because I wanted to do vascular operations. So after they were almost dead or whatever, I would often, open a flank and try and anastomose. In general, I think that anastomosis of an femoral artery and vein in a rat is certainly good training. The only issue with that is you either have to have a lab, or if you're a resident, you have to be in good terms with our preclinical friends, which is a good idea to not only in terms of research, but also let me tell you from experience, every brain tumor modeling lab has rats or mice, or hopefully even pigs that are on their way out. They're already dying, but they do have a cardiac output. And then sometimes, if you're in good, they will be willing to share them just before they're going to anesthetize them, to kill them anyway. You can do a short operation, maybe a 20-minute operation, and they almost all the good labs that do microsurgery will have a microscope. Not the best, certainly not the one you have in your center, but a microscope which you can suture with, which narrows down the problem to all you need to do is bring a Castroviejo or a needle holder and the needles, and then.
Yes, that's the reason that I want to ask about your experience, because like in our unit, we are going to we're starting a lab, and we do not plan to have an animal yet, but that's why I'm also like to ask your opinion. So any experience, for example, in some DIY perfusion model that you come across with or you try to make before?
No, I haven't been successful. And in modeling vascular, honestly, I haven't been successful. I think 3 billion years of evolution did a little better than I did. So just make friends with a lab that puts glioblastoma in either flanks or models, and ask them for their premortem rats, mice, whatever they do.
Thank you, Professor Yin.
Thank you very much, Ben. I think the upsurge model on vascular anastomosis comes very close to a real life situation where you have blood flowing, but it's costly. But you can ask the persons involved.
Thank you, Raj.
Yes, Liu, any comments from your side?
Yeah, thank Professor Fowler to introduce us a very nice, innovative surgical training model that are affordable and with a very strict assessment criteria to assess the achievement of each individual. I just want to bring you towards a future where I always think that neurosurgery is very close resemble aviation industrial, where they have standard of training worldwide. Each aeroplane have its own simulator, and also you can simulate yourself at different airports. So you're going to fly to certain airport, you need to go through certain hours of training with simulator. And I believe this equal to type of disease and type of patient, whether they're adult, they are pediatric, they are patient with anticoagulant. So I would wonder, would this be the future where we have a standard training module? So we don't train on patient, we don't train on cadaver, but we have a specific simulator that resemble the real case, and we have good collection of complication and do we have that at the moment so we can build up with our engineers such model? Thank you, Professor.
That's a great point. I mean, I think it certainly is the where the it will go, and the only thing which is also true for aviation is that you don't really mimic your own tachycardia with a model. You can mimic the patient's tachycardia, you can mimic a bleed, you can mimic an aneurysm bursting, but it's very difficult to mimic, because with a model you just take it off. Oh, I couldn't succeed. Okay, let's go get lunch. That's not what happens. I mean, but you can mimic your own tachycardia, but certainly that's also true for aviation. I presume it's also pretty unnerving when you need to land your plane in the Hudson or whatever. So I assume. I will note that I generally predict that what the models that I am creating may be taken upon in lower and middle income countries, which will almost certainly not be able to mimic. And today, many countries in our region will not be able to afford these simulators, and it'll either be practicing on a patient or practicing on an egg. But for countries that can afford it, centers and countries that can afford it, certainly I agree with you. That will be the way the market is going, I would think.
Thank you, Professor.
Well, thank you very much, Professor Idopaldor and Professor Nupurputi. We had a wonderful session, and you showed us the very effective ways for training the residents in neurosurgery, and we can go back to our chair to hear the final remarks before we move on to the second session.
I think thank you so much, Rada and Professor Paldor, Sung. I think absolutely I love the idea which Dr. Liu gave. That it's not just aviation industry. You look into sports nowadays. The training of sports persons has changed in last 20 years. Our training is still the same. How much extra training they do, how much their focus is there on training. I mean, the more you sweat in training, the less you bleed in battle. Absolutely, that's true. But I think we're still at a very primitive stage with our training. And we need more people like Professor Paldor who are very much interested in this field, and to really change the way that we teach the residents. Last point I would like to make is just listening is not enough. You need to get down to the lab and start working. And start working the first day in the lab is the most difficult day. Once you get to the lab and keep working, believe me, you will not. This message to Ben, if you are listening, Ben, you need to get down to the lab and start working. Okay, and then what Professor Paula told you will make even better sense. You need to get down to the lab and just start working. Thank you so much.
Thank you, and I will surely do that.
Definitely. Ben is from Queen Elizabeth Hospital, Hong Kong. He is with Calvin Mack.
Right.
Of course, he will have a great time learning there. So we'll move on to the second session. Professor Girish Rajpal is here with us. Professor Girish.
Good evening, everybody. It was nice presentation. So we are going to move on to the next presentation, which is the management of cavernous fistula by Professor Zhu Ge from mainland China. And with much ado, I welcome Professor to start his presentation.
Thank you, everyone. Thank you for letting me have the opportunity to share the experience in the management of karate cavernous fistula. Today, I will focus on the different approaches and the techniques. I have no financial ties or conflicts of interest to disclosure. Karate cavernous fistulas are shards that allow blood to flow from karate artery to branches into the cavernous sinus. CCF may be direct or indirect. Barrow has established the classification scheme in 1985. Type A is direct shard. That means direct CCF It is the direct CCF and consists of a defect in the wall of ICA and usually caused by trauma or a ruptured C4 segment aneurysm. And type B, C, D are indirect fistulars, which are also named dural AV fistula of cavernous sinus. Type B is indirect fistula between ICA branches and cavernous sinus. Type C is indirect fistula between ECA branches and the CS, and type D is indirect fistula between both ICA and ECA branches and the cavernous sinus. The etiology of direct CC fistula are trauma, rupture, aneurysms of the cavernous segment, and it may be caused by some inherited connective tissue syndrome disorder like Ehlers-Danlos syndrome. And indirect CC fistula is similar to the AVF of other locations. There is a three-stage hypothesis. Stage 1, the venous sinus thrombosis is in the initial event. And stage 2, microscopic fistulas within the wall of the sinus connecting commingeal arteries to tiny veins and enlarge. Stage 3, recognition of the thrombus of venous sinus occurs and leading to relatively high flow into the cavernous sinus. And concerning the epidemiology of the indirect CC fistula, it comprises about 35% of all DAVMs, which is equivalent to transverse sigmoid. According to literature, it is the most common location for Asian patients. And most patients are women in their 60s or 70s. The clinical presentation depends on fistula point, feeders, and venous drainage. When drained by superior ophthalmic veins, and it may present with pulsating exophthalmos or chemosis, and when drained by IPS inferior protrusal sinus, the pulsatile tinnitus may occur, and if drained by cortical veins, intracranial hemorrhage may occur, and increased cavernous sinus pressure may cause the cranial nerve palsy, and it is called the cavernous syndrome. And if the flow is high, Steele syndrome will cause cerebral ischemia. So endovascular treatment nowadays is the mainstay management of CC fistula. It is effective and safe. The goal is to amble of the fistula points. And one or several compartments of the cavernous sinus will be occluded, usually not the entire cavernous sinus. The approaches include transarterial, transvenous, and direct puncture, sometimes assisted by surgical exposure. Firstly, I would like to talk about the transarterial approach. And transarterial approach is commonly used in type A CC fistula, that is the direct CC fistula, and some selective indirect fistulas when the indirect fistula is limited size, unilateral size, and have few feeders. And the material include detachable balloon coils, balloon and plus coils plus liquid embolics like onyx, and sometimes we use cover stand in the ICA. So microcatheter tip can be wedged into the fistula with an idle position, or we can try to use this approach to treat the indirect CCF. And the detachable balloon embol is useful for direct CCF, and it is associated with tisular occurrence rate of 90% with ICA preservation in 60 to 88% of patients, but it is not available in some countries. Case 1 is a typical CCF patient presented with chemosis. And from this picture, we can see this patient has a left ICA cavernous fistula, good collateral from the contralateral side, and a detachable balloon was used to occlude the fistula completely with ICA patency. So the procedure is simple and the result is good. The other case is a 25-year-old male and suffered from left exophthalmos and brood. Angio showed fistula was at the anterior lateral wall of ICA here and joined by SOV and IPS. Detachable balloons embo was performed and the fistula was occluded completely. Unfortunately, when we post the procedure, CCF recurred. And you can see on angiography, we can see the balloon may migrate. So the second surgery we performed, we use coils and artics to embo the fistula. Unfortunately, 1 month later, coils migrated and leading to CCF recurrence. Yeah, the balloon and the coils migrating. And the third surgery has to be done. This time we use cover stent, super selective angiography with microcatheter to find out the exact location of the defect first, and one stent was deployed here. It's a balloon mounted stent. Control run demonstrated the endo leak existed between the stent and the vessel wall. Angio from distal of the stent was performed, and there was an endo leak. You can see the blood flow outside the graft into the sinus. So bridge stent at the distal segment. That is a 4 by 13 millimeter stent. Another angio demonstrated endo leak from the proximal end, and one more stent was bridged proximally. And this 4.5 by 13 millimeter stent. But finally, the fistula was covered successfully, and the ICA was patent. This is another case, 30 years old male, and he suffered from 1 month. He has a 1 month history of rapidly progressive pulsatile headache and bruise and redness in the right eye, and with a remarkable past medical history and family history. He never suffered from trauma, but several angiography revealed a rapidly filling direct CCF involving the C4 segment of the right carotid siphon and drained by right SOV and bilateral IPS. That's a spontaneous direct CCF, a rare case. No feeling from ECA, and there's no collateral from the left. A gold balloon was placed through the defects in the cavernous sinus. There was still feeling. So the defect is relatively large, and the coils and onyx injection was performed. And during the onyx injection, a balloon was inflated inflated to protect the ICA. Here's the coil mass, and this is the balloon. The fistula was sealed successfully. 2 years later, the same symptom occurred in the left eye, in the other eye. And angiography was performed, and we see that there's no recurrence of the rights. However, there was an aneurysm at the segment. So we had to perform. Okay, another the left ICA demonstrated fistula. So we performed another surgery. And the fistula was sealed successfully of the left side. Gene analysis demonstrated mutation in the patient and 5 of his family members, which is responsible for a series of abnormalities. And this is diagnosed as Ehlers-Danlos case type 4. It is a rare autosomal dominant collagen muscular disorder. And this is another case. It's a symptomatic indirect CCF, barotype C. From video, we can see it is fed by branches of MMA, middle meningeal artery. The fistula have a small size and a few feeders. So transarterial onyx injection is an option for this kind of cases. And here is the onyx cast. And during the procedure, the tip can be wedged into the distal feeder, and complete amble was achieved. And transvenous approach is most effective technique for indirect CCF, and the coils and the onyx are the most commonly used material. Several different routes to cavernous sinus. The most commonly used are the inferior pertusal sinus here, and the SOV superior ophthalmic veins, and sometimes achieve access through the pterygoid plexus from the inferior, depending on which is easy to advance. Trans-IPS is usually the first choice, and the successful amble of CCF through IPS is reported in 64% of cases. Thrombosed IPS can be traversed successfully in about 50 to 90% of cases. Stiff guide wire and a stable proximal support is helpful. Usually, I would like to use a 0.35 guide wire and a 4 French catheter to probe and reopen the occluded orifice. Now look at this case. It's a typical indirect CCF and fed by branches of bilateral ECA and ICA, drained by IPS, by the left IPS. So here we advance the microcatheter into the cabinet sinus through the IPS. And the coils and the onyx were used for embolization. Here's the post-operation angiography. A complete embo was achieved. And this is another case. It's a 66-year-old female suffer from chemosis and redness of both eyes. And angiography demonstrated that it's bilateral type B CCF and joined by bilateral SOV here. For this case, IPS was invisible. But we try to traverse the invisible IPS. And we put the catheter through the right jugular vein and looking for the roots, probing. And now we put the catheter into the we arrive at the right sinus and get into the left sinus through the intercavernous sinus. And I would like to place the tip of the microcatheter close to the SOV here. Make angiography. Here is the SOV and the Sylvan vein. Then we place another catheter into the right cabinet sinus. Here's the macro catheter. Okay, advance here. And calling begins in the posterior part of the SOV and extend to the cabinet sinus. Here is the SOV. So we do that to ensure the flow do not redirect it into the orbit. And then onyx injection into the cabinet sinus. We monitor the onyx cast and the roadmap. And repeated angio. Now here is the intercavernous sinus. Still some feeding. And continue injection. And then we inject onyx with the other catheter in the right sinus. Okay, yeah. And control angel demonstrated fistula was obliterated completely. Here's the coil and onyx test. And SOV can also be used for catheterization. Here is the anatomy through jugular veins and the facial veins and to SOV. This route is used only when SUV is the main drainage and the facial vein is enlarged. And this is a typical case drained by SOV, only by SOV, and we can see the enlargement of the facial vein here. And we perform the catheterization through facial and SOV. Here's a coil. And the fistula was obliterated completely. Sometimes direct surgical exposure and cannulation of the SOV can be used as an alternative approach. And it is a good alternative treatment when conventional venous routes are inaccessible. Look at this case. And the fistula is drained only by SOV, but the facial vein did not enlarge. So assisted by surgical exposure of SOV, a microcatheter advanced into the cavernous sinus. And coil and the onyx amble was performed. And it is sealed completely. Sometimes we can get into the cavernous sinus through other draining veins, like cortical veins, which can be accessed surgically or endovascularly. Open surgery can help expose the veins, and calculation is performed. At the same time, we can evacuate the hematoma if the patient suffers from a hemorrhage. A couple of papers have reported this route. Not many cases so far. Here's a case from Beijing Tiantai Hospital. A fistula is isolated with isolated cortical vein drainage. That is a sylvian vein. We expose this vein by surgery and cannulation and catheterization. After onyx injection, complete embolism was achieved. Direct puncture is an alternative approach as well. According to literature, these specific cases were performed through transorbital route when endovascular access is not possible or fails to occlude the fistula. And our hospital has reported a transnasal and transsphenoidal case to treat CCF. I will mention that case later. Now here's a case report from Beijing Tianpan. A needle was inserted percutaneously at the junction between the lateral third and the middle 2/3 of the infraorbital. And the fluoroscopy, the needle was gradually advanced towards the superior orbital fissure. And EMBO was performed. It is a successful case. That's a case from our department. It's female, 63 years old, and suffer from recurrent chemosis and bruise for 7 months. MR scan demonstrated minor veins in arterial phase. Preoperative angio demonstrated right ECA angio. This right ECA angio demonstrated drain by some cortical veins and enlargement of compartments of the right canal sinus. The lateral view. And this is the left ECA angio. Here the fistula and the enlarged canal sinus here. Also some feeding from both ICA. Percutaneous transverse access to the fistula through the inferior from the IPS was attempted but failed. Is there any other alternative route? MR show, okay, here, MR show the enlarged compartment here of the canal sinus adjacent to the cellar. So I would like to try direct puncture, transnasal, and transsphenoid, just like the adenoma surgery. First, incise the mucosa, and then drill the sphenoid. Following the hemostasis, a puncture was performed. Here's the needle tip. Angiography confirmed it is right in the compartment of the canal sinus. Through this needle, we insert a microcatheter under the fluoroscopy. The microcatheter advanced into the left canal sinus. A coil was placement, and before onyx injection, a balloon was used to protect the retrograde feeding of onyx fluid. And here is the onyx injection. And totally, 4.2 milliliter onyx was used. The control angel. The fistula was embolled completely. After procedure, the patient made an eventful recovery. All symptoms disappeared. And 6 months clinical follow-up, no recurrence. Cerebral angiography obtained 12 months following the procedure, confirmed a complete obliteration of the fistula. Both sides. So another measurement is manual compression. A patient is instructed to press the carotid by himself gradually until the palpable pulse is stopped. Compression is maintained about 10 to 15 seconds at a time, 2 to 3 times an hour. Opposite hand is used in case hemisphere ischemia develops. The cooling rate was reported to be 30% for indirect CCF at 6 months and 17% for direct CCF at 12 months. Here is a patient. She is a female and suffer from proptosis of left eye, and MR scan show the enlargement of ophthalmic vein. Following 2-month compression, she recovered clinically and angiographically. Here is December, and this angiography is performed in February the next year. So let's come to the summary, and the CCF may be direct and indirect. And in the vascular treatment, it's currently a first-line choice for this disease involving that do not respond to compression. Trans-arterial embolism is useful for direct CCF, and trans-IPS access is usually the first choice for indirect CCF. And an alternative route should be considered after conventional access failed. Thank you for your attention.
It was very nice presentation and very crisp and elaborate. So I thank from the team members to Professor Zhou. So I would like to ask, how do you identify multiple entry points if there is multiple punctures for the fistulas?
Sometimes we can, if we cannot see it clearly, we can use non-detachable balloon, and we inflate it in different segments and make angiography to see where is the defect.
Okay. And how much the superior ophthalmic vein you take in the occlusion?
The SOV is high pressure, so I don't think it has any function. So usually we can, but when we inject the onyx, we must pay attention not to make it into the orbit, make retrograde filling into the orbit. We just occlude the orifice of the SOV.
Okay, great. So I would ask the audience to ask any questions.
There aren't any questions so far. So you may conclude, Professor Rajpal, give your concluding remarks. So
I would like to thank Professor Zhu for the presentation, and it was very nice presentation.
So thank you very much. We had a wonderful session about CCF, and Professor Gao showed us so many techniques how to deal with CCF, and we are extremely grateful. So I'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Ido Paldor, as well as Professor Gao Zhu, and the chairs, Professor Nupur Pruthi and Professor Girish Rajpal, for their time and support for the ACNS webinars. I would also like to express my sincere gratitude to Professor Shubin for broadcasting this on the WeChat channel, and also to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.